Good morning and welcome, everyone. We want to thank you for joining the Scleroderma Foundation Minnesota Chapter Patient Education Conference. My name is Chris Mays. I'm the president of the Minnesota Chapter Board of Directors. Today, we are very pleased to welcome Dr. Jerry Molitor and Dr. JoAnna Harper. There's a lot of information to cover today, so we want to get started. But first, I need to do a couple of quick notes for today's event. If you're properly logged into today's webinar, you should be seeing the slide on the screen and hearing my voice. If you've dialed into the event by phone, please turn your computer microphones down or mute to avoid any sound feedback. Today's webinar will be recorded and will be made available after its broadcast. The Scleroderma Foundation is in no way endorses any drugs, treatment, clinical trials, or studies referenced in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation. This webinar is for educational purposes only. We encourage the attendees to use the question chat feature on the sidebar, and we will be hosting a 15-minute question and answer segment after each presentation. Please note that we will do our best to get through as many questions as possible. All right, the first presentation, I'm delighted to introduce today's first speaker, Dr. Jerry Molitor. Dr. Jerry Molitor is the Associate Professor of Medicine in the Division of Rheumatic and Autoimmune Diseases at the University of Minnesota Medical School. Dr. Molitor was previously Adjunct Assistant Professor of Medicine at the University of Washington, as well as Director of the Arthritis Clinical Research Unit, Associate Director of Clinical Research and Head of Rheumatology at Virginia Mason Medical Center in Seattle, where he worked with Dr. Daniel First. Dr. Molitor now leads the multidisciplinary scleroderma clinic at the University of Minnesota. He has been involved in over 60 clinical and translational research projects, including multiple clinical trials of treatments for features of SSC, including Raynaud's phenomenon, digital ulcers, interstitial, I accidentally got a frog, can you pardon?
Interstitial lung disease and pulmonary hypertension.
Thank you. Sorry about that. Dr. Molitor has been named continuously to top doctors lists in Seattle, the Twin Cities, and nationally from 2007 through 2020, and has been a medical advisor to the Scleroderma Foundation local chapters in Seattle from 2002 to 2007, and here in the Twin Cities since 2007. Dr. Molitor will speak on current treatments for scleroderma lung disease and on the screening, tests used to diagnose and follow severity of those conditions so the therapies may be optimally adjusted. So thank you very much for joining us, Dr. Molitor. And momentarily, the screen will be yours to start your presentation.
Thank you. Okay, I have been made the presenter. Please close confidential windows. I don't have any of those. So right now, that's gonna be my end. So can you all see my screen? Can you see the slides?
Yes.
Excellent. So I'm gonna move this little guy out of the way. I guess I'm just gonna close it because I can't get it out of there. No, I do not want to leave the webinar. I'm trying to get this little thing out of there, but whatever, we're going to work with it in the bottom corner. And you all know I'm at the University of Minnesota and that it's driven to discover. So the fact that it's screening that part out, we'll get by without. Now, thank you for that very nice introduction. I do want to say that I decided that since some of you may have seen the national talk that I gave a few weeks ago, that I wanted to give you a little bit of additional information. And I'm going to talk almost not at all about treatment right now. That talk is available to you. And if you want a little bit more information on the treatment options for scleroderma interstitial lung disease, which is what I focused on in that talk, and how the screening tests are used to help us decide those decisions, you can refer back to that talk. I decided that it would be helpful to speak a little bit more broadly about screening tests, which are not always clear to patients exactly why we're doing them, when we're doing them, and how we actually use them. So I think that would be helpful for the group. I'm happy to take questions, including questions about treatment later. The other thing, the other thing I do want to let you know is, although there was a hiatus in doing some clinical trials, even nationwide and with us, because of the coronavirus concerns, we are going to be up and running again, doing some clinical trials with extensive precautions, including the possibility of doing some trials from at home. So the people who do trials have gotten pretty creative about that. So to give you a simple one contact number, and then Lee can pass things on. Lee Anderson, my nurse, has shared her phone number here, and I didn't put it up on a slide, but we'll make sure that's available on the website too. And it's 612-676-5876, and that's either for an appointment or to do some of the research activities. We are seeing a small number of patients, primarily new patients in person and patients who need to have certain tests or a physical exam. So just to let you know about that. So without further ado, I'll move on. And here are my disclosures. As most of you know, I've been an investigator on a great many trials, and this is a current list. There's a couple new ones coming up, and I've been a consultant to several companies, primarily in terms of thinking about their development programs and what makes sense in systemic sclerosis. So here are the objectives. I'd like you to be able to learn what the most common screening tests we use broadly throughout the field in terms of thinking about the clinical manifestations of systemic sclerosis, and understand why we do screening tests and how they help us treat disease, and understand how closely to watch you as well. And then review the spectrum of scleroderma lung disease specifically, and how we use screening tests to decide on treatments and modify them when necessary. Why are we using screening tests? Well, to think of it broadly, we screen as part of both a diagnostic and prognostic strategy based on clinical history. So as I just said, people with certain tests that are positive or negative may need to be watched more or less closely. We screen specifically when we can treat. So we would like to have a good screening test for certain things, but we are less likely to be trying to screen for something if we don't have a treatment. We screen only as often as we would make changes in monitoring or in treatment as a result of the test. So sometimes our screening test is a very broad screening test, and I'll show you an example of that when a more specific screening test then becomes indicated. And some screening tests, as I just said, beget other screening tests. So if you have very low red blood cells, it makes us concerned about gastrointestinal bleeding, and then we may want an upper endoscopy. That's just one example. In general, however, the longer you have stable disease, the less frequently you need tests. So those of you who have been coping with your condition for 5 to 10 years may not need tests as frequently as those of you who are in the first 1 to 2 years. There is an exception to this, and some of you occasionally will have a real flare of your disease later on. Fortunately, systemic sclerosis does not do this to the degree that certain diseases like lupus do. But if you think you're feeling a big change, for example, your exercise tolerance, which can be the case with systemic sclerosis lung disease, we very much want to hear from you. And we would do your rescreening sooner. Oops. So what makes a screening test good? Well, number one, it has to be easy to administer and tolerate. A test that requires 3 days commitment on your part is not a particularly good test. It has to be a reasonable cost. We don't want to have to fight an insurance company every time we want to do a test because of the cost of it. It has to have high sensitivity. That is, it has to find the condition when it's there. So if a test is 100% sensitive, it will always find the condition if it's there. If it's only 50% sensitive, it'll only find it half of the time. So that's not so great. Although there are cases, and I'll show you later, where that is good enough for a screening test that is very difficult to be sure of, to make sure we get a gold standard test that we're absolutely sure of. It has to be good enough specificity that it doesn't generally suggest the condition is there when it is not, at least most of the time. So if it's 100% specific, it will never suggest the condition when it is not. A test that frequently suggests that you have a problem when it's not is a more difficult test. And we'll talk a little bit about the one that is most troublesome in rheumatology, in a sense. And sensitivity is really the more important of the two when treatment is good, and particularly if treatment is good and the disease process is bad. So if the disease process can really hurt you over time, we really want a highly sensitive, and we have a treatment, we really want a highly sensitive test. So let's talk a little bit about autoantibodies. So I was going to put a slide in here, but in the interest of time, I did not, about the ANA. The ANA is the anti-nuclear antibody, and it has been broadly misunderstood. An ANA can pick up an antibody that is raised against any protein in your nucleus. That is never totally normal, and yet it happens in up to 30% of people, at least transiently. And there probably are many ANAs that never produce any problem that's severe enough to qualify as a disease. The ANA has also repeatedly falsely called the lupus test. So you get an ANA, and someone who is not particularly well versed will say, oh, you have a positive lupus test. The ANA is not the lupus test. There is no single lupus test. And most patients with systemic sclerosis will have a positive ANA. And this is an example of a screening test that we may do under certain circumstances. For example, Raynaud's phenomenon. If it's severe enough, we may do an ANA. And if the ANA is positive, that then prompts us to think about several conditions, including systemic sclerosis, that can have an ANA. So the vast majority of scleroderma patients have an ANA. And then we move on to a specific autoantibody screen. So I'm going to go through the autoantibodies because they have prognostic significance. And that's become more important over time as we've developed some treatments that actually are working for systemic sclerosis. So the first one, and this is relevant to our discussion later of lung disease screening and treatment, is the topoisomerase antibody. And this is seen in 20 to 40% of systemic sclerosis patients. It's strongly associated with interstitial lung disease. So about 40 to 50% of people with an anti-topoisomerase will have at least some degree of interstitial lung disease, although that still means that 50% don't. There's variable gastrointestinal and skin involvement and variable severity of those features. It can be seen in Scleroderma sine sclerodactyly, which is this weird category where we see the antibody, we see interstitial lung disease, we see gastroesophageal dysmotility, but we can't find any skin involvement. And so this just goes to the clinical heterogeneity of systemic sclerosis. There's an approximately 5% false positive rate on this test as done in most laboratories. So that is, it's less than 95% specific. If we get this test positive, but it does not fit with the clinical picture, that is, we find no other manifestations that would make us think that you have systemic sclerosis, there is a send-out test we can do called the immunodiffusion assay. And that has 98 to 90, and there's a couple of these tests that are not immunodeficient assays as well, the diffusion assays as well, but they're very specific. And we can send those out, and those have 98 to 99% specificity. If those are negative and you don't have clinical features of scleroderma, you don't have scleroderma. And this test is very scary to people because they get this back and sometimes they're simply told by the doctor who ordered it, well, you have scleroderma. That's not necessarily true. Scleroderma autoantibodies also include the anticentromere antibody, and this is one of the most common of all scleroderma antibodies. It's seen in about 30% of limited cutaneous systemic sclerosis or CREST patients. Rarely do we see it in a patient who has skin features more consistent of diffuse cutaneous. This is also seen in people with primary biliary cirrhosis, most of whom have already had clear-cut clinical features of limited cutaneous systemic sclerosis. Many of you will notice that I often ask, particularly when you've had your crest for a long time, if you're having any significant problems with skin itching. Now, almost everybody has some skin itching in the winter around here, even people who don't have systemic sclerosis. But if you're having more and more skin itching, sometimes we check for the lab test called alkaline phosphatase. And if that's up, we start to concern ourselves about this. Fortunately, there's a very good medicine for this these days, and this is another reason why we want to screen for it, because if you're developing this, we can get you on that medicine with the gastroenterologist, and most people never progress. This is actually being renamed because so few people progress to cirrhosis, and we're tired of scaring people with this title. So this can be seen in the centromere can be seen in Raynaud's without development of other limited cutaneous systemic sclerosis features. Having the anticentromere antibody does not necessarily mean that you have or will develop clear-cut crest, although some people do develop limited features of it, such as a little bit of gastroesophageal reflux. Some data sets indicate that there's an increased risk of pulmonary arterial hypertension. That's still a little bit controversial. There's a definite decrease in interstitial lung disease risk if you have this. And there are newer data that are very interesting that it suggests that if you have this autoantibody, you have a decreased risk of an underlying cancer, which has become a very hot area for research, is to understand whether certain autoantibodies, both in systemic sclerosis and across the board, have an increased or a decreased risk of an underlying cancer. We know that autoimmunity can develop in the setting of cancer. Does the nature of the autoantibody tell us something about whether the immune system has gotten rid of the cancer or has failed to get rid of the cancer? And that's a hot area of research. Here's a picture of anticentromere antibodies. If you're a rheumatology fellow and you want to become a board certified rheumatologist, you better know what those look like because that'll be on your test. Is it idiopathic Raynaud's phenomena or early systemic sclerosis? This is a question we get all the time in people who've developed Raynaud's. And there is a couple of important screening tests for this. We already talked about the ANA. But part of any good screening strategy is to take a good clinical history. And so we'll ask, are there any other systemic sclerosis features, such as bad gastroesophageal reflux? In other words, if after you eat, if you bend over, is food up in your throat? Or do you just constantly have the symptoms of something feeling like it's coming up? Are your hands swelling? Onset in childhood or puberty tends to mean idiopathic Raynaud's. But if it comes on later in life, it's much more likely to be associated with systemic sclerosis or other similar autoimmune diseases like mixed connective tissue disease. Is it having worsening frequency, severity? And are you having increasing difficulty in aborting attacks? Those of you who see me know that I'm constantly asking, is it happening more often? Is it more severe? Is it harder to get your attacks broken by rewarming? That's a feature of systemic sclerosis, much more than idiopathic. Are you getting digital ulcers? And then the anti-nuclear antibodies, once again, broad screening for autoimmunity, not the lupus test. And finally, nail fold capillaroscopy. Now, nail fold capillaroscopy, shown here, can be totally normal with these normal little, and this is magnification. This is about a 20-fold magnification here. And this is done with a capillaroscope with a camera attached to it. But we can do this as simply, and you'll have seen me do this, again, if you see me, with a ophthalmoscope. and a little bit of KY jelly over your nail beds, your cuticles, so that we can see things better. And this is what we see sometimes in early systemic sclerosis. We see these dilated loops. Later on, we can see areas that are so damaged that there are no loops, and there are these telangiectasias all over the place, just like the telangiectasias one can get elsewhere on the body. And this is very helpful, because if we see this is much more likely early scleroderma. But if we see this in somebody who's had Raynaud's for 10 years, this is much more likely idiopathic Raynaud's and not likely to progress. There are additional autoantibodies that we used not to be able to get, and now we can get on a send-out screen. They are important for us to understand, but harder to put into a prognostic category. But we have some information. Antifibrillary antibodies, also called the U3-RNP, seen in about 5 to 10% of patients, tend to go with diffuse cutaneous disease, with interstitial lung disease, and or pulmonary hypertension, and with myositis. Not all people get all of those. Some people don't get any. THTO is one of the least common antibodies that we can actually test for. There are other very uncommon antibodies that we don't even have commercially available. And this goes together with the limited cutaneous systemic sclerosis phenotype, but oddly, unlike centromere, shows an increased risk of interstitial lung disease and also an increased risk of renal crisis. So if you have this antibody, we watch you in the way we do early bad diffuse cutaneous systemic sclerosis for renal crisis. The PMSCL, seen in 5 to 10% of systemic sclerosis, also goes with limited cutaneous systemic sclerosis phenotype. Often these patients will get calcinosis later on in their disease process, and will often start off with myositis, inflammatory muscle disease with a lot of weakness, but have a decreased risk of lung and kidney disease in general. And then finally, there's the anti-RNA polymerase III antibody. And this is the antibody that many, if not most of you who get really rapid, severe early skin worsening have. It tends to go together with tendon friction rubs, although those can also occur in other antibody subsets like topoisomerase. This is an important prognostic feature we've learned due to some beautiful research at Johns Hopkins that's been confirmed in the large European scleroderma cohorts, that there's an increased risk of an underlying cancer in those of you who develop this antibody. That's true primarily in the first 1 to 2 years after systemic sclerosis onset. And I mentioned earlier that sometimes these antibodies may be associated with a cancer, but a cancer that your immune system has already successfully cleared from the body. And so we screen for cancer if you have this antibody now, particularly if you're in the first several years of disease. We don't tend to screen if you're 10 years in, because we don't find it. We don't think that there's cancer still going then. There's an increased risk of heart involvement, including arrhythmias. We have to pay attention to that if you have this antibody and your skin got bad fast. And there's a significant risk for the development of scleroderma renal crisis. So what is the most important screening for renal crisis? And we do want to screen for renal crisis because it can sneak up on us so badly. Home blood pressures are the mainstay of screening for renal crisis. It is possible to get renal crisis without an elevated blood pressure, but it is very rare. So by using home blood pressures at least 3 times a week, especially early on in the disease process, if you're many years into it and things have quieted down, probably once weekly is enough, as long as you really do it and keep track of the blood pressures. We're always concerned if the blood pressure has risen over a matter of a relatively short time, a number of weeks, by 30 millimeters of mercury on the top number, the systolic, or 20 millimeters of mercury on the bottom number or more. The RNA polymerase III antibody we just discussed is one of the key things that we look for, as well as the THTO. The creatinine number, the kidney number, if it's climbing, that's always a concern. And then the urine protein. Some people with this will have low levels of urine protein elevation. It doesn't tend to be a lot. And then the echocardiogram. If blood pressures are high, you can get what's called left ventricular hypertrophy. And if you have left ventricular hypertrophy, it's a clue that you've had high blood pressures. Let's talk a little about the gastrointestinal system, and upper endoscopy is in fact a screening tool. We use if there's this clinical history again that suggests it needs to be done, and the history of worsening reflux, unexplained anemia, or low red blood cell counts, difficulty with swallowing, pain with swallowing, and tobacco use with even minor of the above symptoms, because tobacco use increases risk for most of these problems. It's used to rule out esophageal stricture or narrowing of the esophagus from scarring, which we see quite a bit in systemic sclerosis, and a number of you will have suffered with this and had to have dilatation done through an upper endoscopy. It's used to find erosions or ulcers, which can be quite painful when you swallow, and that's one of the clues there. It's used to rule out esophageal thrush. This can happen in patients who are on aggressive immunosuppressive therapies, particularly like CellCept, which we use a lot of. And it tends to happen more if you've also been on a prolonged course of antibiotics, which take away some of the bacteria that fight with some of the fungus that causes thrush. And then to find any evidence of malignancy or the pre-malignant changes called Barrett's esophagus. So it's important for this. And finally, if you're bleeding and we can't figure out why, and typically this is like these very slightly low blood counts that keep creeping down and we can't figure out where the blood's going. Often this is where it's going, particularly if you have a lot of telangiectasias elsewhere. So here's some pictures. This is esophageal thrush. All these pictures are from either the American College of Rheumatology website or from UpToDate. Most of them are from UpToDate, which has some really nice pictures for this stuff. This is esophageal thrush, and this, any of you who've had thrush in your mouth know how these little white fluffy cotton-like areas look if you've looked in the mirror, and this is what they look like in the esophagus. Now this is particularly bad. This is from an AIDS patient with who has very little immunity against thrush. In a patient who's got thrush because of some aggressive immunosuppression, it doesn't tend to look this bad. And here's some nice pictures. Nice if you're not eating breakfast. Balloon dilatation of a peptic stricture in the esophagus. So you can see here, this is the balloon. So here's the narrowing. Here's the balloon that's expanding it, and here it is once it's been expanded. Now, balloon dilatation tends to work best for these for a very small area of stricture, but for a larger, more a larger area of stricture that keeps going for quite a ways, they use these dilators, and many of you will have experienced that. And here's Barrett's esophagus, the endoscopic appearance of Barrett's. So there are long segments of columnar epithelium. That's something you don't need to know, but I guess if you're a gastroenterology fellow, you're supposed to. And this is the characteristic appearance of this. And if you have Barrett's esophagus, they will want to go back in typically with a laser and or radiofrequency ablation, and they'll take out some of these areas and want to also keep watching you pretty closely with endoscopy more frequently, because that can progress to esophageal cancer if it's bad and if it's simply left to its devices. Once again, this is definitely worse typically in people who are smokers. So the combination of being a smoker and having bad gastroesophageal reflux with acid continually spilling up onto the esophagus puts you at particularly high risk of this. Here's gastric antral venous ectasias, and so these red areas can all bleed, and this used to be called watermelon stomach, and that's kind of going by the by as an explanation. So here's the survival in scleroderma curve that pretty much everybody shows, and it's still one of the things that that is, I think, most informative in terms of thinking about why we screen and how we screen. So this is these are old data, and these have improved a little, but not dramatically over time. So if you have no heart, lung, or kidney involvement, your survival over 10 to 12 years is quite good. And this is all patients. So this is that we're in this cohort. So this is some people who are, you know, somewhat advanced in age in some cases. And this is not a horrible step off, and it's not a horrible step off for sure in the first 7 years. But if you have lung involvement, interstitial lung disease, it's clearly worse. And there's clearly a steady decline in survival. And if you have pulmonary arterial hypertension, it was not good at all. These curves have improved. And so why do we do screening tests? Well, in this situation of lung disease, multiple pulmonary hypertension therapies alone and in combinations are bending that really bad curve. There's increasing evidence that we have therapies that can bend curve B, which is primarily ILD. There's additional therapies for both of these conditions in development, a number of them actually, and some pretty encouraging ones. There's good evidence that the sickest patients who contribute disproportionately to the ILD curve get a mortality benefit from stem cell transplant, and not just a mortality benefit, they feel better. And there is increasing evidence that certain systemic sclerosis patients can do well with lung transplant. 10 years ago, a scleroderma patient could not get a lung transplant. That was almost impossible. Centers were too afraid of complications in systemic sclerosis patients. But over time, we've really learned that there are patients who can do well with lung transplant. It still takes very careful thinking about whether a patient is a good risk for lung transplant, because lung transplant is a hard road, and not everyone is going to do well on that road. So causes of shortness of breath. So the first thing with most screening, as I've already alluded to, is for us to take a good history. Are you having this problem at all? Well, if you're having shortness of breath, particularly with exertion, lung disease is the one we're going to focus on, but heart disease can give you shortness of breath. Quite significant anemia, if your red blood cells are low enough, can give you shortness of breath. Actually, if you have myopathy, you can feel short of breath even though the real problem is in your muscles. And a lot of that is because the muscle at the base of your lungs is critically important for how well you breathe, as are the muscles in between your rib cage. And then finally, deconditioning. Just, I've got a couple of patients. I just talked to a patient yesterday who feels more short of breath over the last 6 months, but when I've done all the tests looking at their lung function, and then when I do that, they're all pretty stable, but it turns out he's really stopped exercising. So deconditioning may be enough in some cases. So types of scleroderma lung disease, we already kind of talked about this, and I think most of you know. Interstitial lung disease, pulmonary hypertension, pulmonary arterial hypertension is a subset. This tends to be what people with CREST, limited cutaneous systemic sclerosis, particularly those with the anti-centromere antibody, are more likely to have. But there also is pulmonary hypertension secondary to chronic low oxygen, WHO type 3 pulmonary hypertension. You can get this from conditions as diverse as sleep apnea and chronic COPD or asthma, but interstitial lung disease in the case of the scleroderma population is the main one. There's this rare condition called pulmonary veno-occlusive disease that can happen in scleroderma and happens to a small percentage of patients. And of course, we always have to worry about blood clots. I mean, there are scleroderma patients who get blood clots, and that can usually prompt a fairly sudden drop in your exercise tolerance. It's fairly sudden worsening of dyspnea or shortness of breath. So scleroderma ILD, we already talked about the SCL70, the topoisomerase 1. The anti-centromere definitely decreases risk, as does the PMSCL and the RNA polymerase 3 antibody. If you have those, that doesn't mean you can't get scleroderma interstitial lung disease, but we worry about it less. We don't necessarily ask you to do screening tests like the HRCT scan very frequently. In fact, sometimes we do a first one if it's normal and your pulmonary function tests remain normal. We may never repeat that. It's more likely in diffuse cutaneous systemic sclerosis than limited cutaneous systemic sclerosis, but it can occur sine sclerodactyly. So those patients who don't seem to have any skin involvement, but have suggestive antibodies such as the topoisomerase 1, we still want to watch you quite closely, particularly early on. The high resolution CT scan is the sort of gold standard diagnostic test. If we see it on there, we know you have it. We don't know whether it's going to get bad necessarily, unless it's bad when we first look, but we know we need to watch it. So this is one of those cases where if the screening test is positive, that means your follow-up is also more frequent. And we advocate doing this in almost all patients with newly diagnosed systemic sclerosis. There are a few isolated situations where we might not do it, but in general, that's been a real change in thinking. And there's a lot of data behind that change that I won't go through. Pulmonary function tests, both lung volumes plus what's called DlcO, and I'll go through this a little more, are used to monitor for stability. Well, why is all this happening? Well, it's happening because we've really advanced in terms of thinking about treatments. Cyclophosphamide has been around for 20 years as an ILD treatment, but it's got a lot of downsides. It can cause a lot of trouble over time, and we've talked about some of that before. And you know, we can go through a little. You can see some of the data for cyclophosphamide in the talk I gave to the national conference. Mycophenolate mofetil, Cellcept, or its cousin that is helpful for people who have too many gastrointestinal side effects, Myfortic. All those can be helpful. And this has been very conclusively shown now in several trials, including in the nintedanib trial, which really showed that there is a role for this as well as for nintedanib. I'll show you a slide to that effect, and that's the only other treatment slide I'll show. There are some limited data that would advocate the use of rituximab, limited data that would advocate the use of Actemra or tocilizumab, and I've talked about this with a few patients. Some of you may have had that conversation. Autologous stem cell transplant, what the big trial in the United States, the SCOT trial, clearly showed, is that people with interstitial lung disease were likely to benefit from autologous stem cell transplant. Now, most of the people that were in that trial had quite significant disease. And when you look at the totality of that trial, these were the patients who benefited the most. And then lung transplant, where we have very limited data, but some very encouraging outcomes going on with some patients. And we may have one or two of you in the audience. So nintedanib or OFEV, the pivotal trial was the Census trial. And this was published in the New England Journal of Medicine last year. And this clearly shows that if you get on nintedanib, you are less likely to have deterioration in your lung volumes over time. And we know that deterioration in lung volumes over time is associated eventually with the need for oxygen and a higher likelihood or more rapid progression to death as well. So nintedanib, also called OFEV, it showed the following data when you broke it down in the trials. And I do want to hasten to add that some of these numbers are not statistically significant, and so they can't necessarily be considered valid. And yet, when you look at the trends here, I think the trends are quite informative. So historically normal lung controls will lose about 20 to 25 milliliters of volume a year. That's not a huge amount, but it's enough that over a decade you may notice that you really can't do things quite as well as you used to. If you look at all the nintedanib negative study placebo patients who didn't get any nintedanib, they dropped about 4 to 5 times as badly in that year. If you didn't get nintedanib but did get mycophenolate, you only dropped about 3 times as badly, but you still dropped. If you didn't get nintedanib or didn't get mycophenolate, either one, you dropped by 120 milliliters, 5 to 6 times as badly. Now, if you got nintedanib, you only dropped by 52 on average, by 66 if you were on nintedanib but not mycophenolate, almost identical to if you were on mycophenolate and not nintedanib. But if you were on both, you only dropped by 40 milliliters. At worst, twice what you would as a normal lung control. This is a huge difference, dropping by 40 milliliters and dropping by 120 milliliters if you run that out over 10 years. This becomes a very big deal. Dropping your lung volume by 800 milliliters over 10 years is an important and significant drop. And so I show this slide because this gives us part of the context for why we keep telling you, yeah, we want to do your pulmonary function test again in 6 months or even in 3 months. If you're dropping, we're trying to get that drop to stop. And if we can put you on a combination therapy now, nintedanib plus mycophenolate, and you tolerate that, and we can get your drop to go to normal or nearly normal. Remember, this is the average. There are people in this group that did essentially this well, and there are people who didn't do quite that well. So we're really trying to get you to where you're basically completely or almost completely stable. Well, pulmonary hypertension, we want to go through again briefly. There's pulmonary arterial hypertension, and then there's group 3 pulmonary hypertension, which is due to chronic lung disease and or chronic hypoxemia. It is really important to point out that if you're often very short of breath, you may well be hypoxemic. And if you're hypoxemic, you are taking a risk that this is getting worse, that you're developing this. And so 10 to 15% of systemic sclerosis patients will develop pulmonary hypertension. It remains the leading cause of death, with 2-year survival rates based on several recent cohort studies that are significantly better than in the Go et al. Paper that I showed you, but still not great. We already talked about the serologies, and I won't go through that again, but systemic sclerosis patients with SCL70 antibodies are more likely to have their pulmonary hypertension due to group 3 pulmonary hypertension, chronic hypoxemia. And we use several screening tests because none of our screening tests for pulmonary hypertension are that great. So we use them in combination. And then if we think your risk is high enough, we send you to the cardiologist for right heart catheterization, which is the gold standard to make the diagnosis. Right heart catheterization is not a good screening test. It's invasive. You have to come into the hospital. You have to have a catheter placed either in your neck or your groin. In good hands, it's quite safe, but there's always the possibility for a serious side effect with a study that runs a wire up into your heart, which is how this works. So it's very important, if it looks like you have pulmonary hypertension, that we get you on the right treatments, but we don't want to just do this in everybody every year. So without going through each of these, there are a lot of therapies now for pulmonary hypertension, and there's no doubt that we are able to keep people highly functional for much longer than we used to. And in some cases, we seem to arrest the worsening of the disease. So there are some very good drugs here. We use typically in combination an ERA and a PDE5 inhibitor. A few people get this drug when their situation is very specific. And then if people are getting worse, we use the prostacyclines, and these are quite effective in many people. Oops, I may have had that in there twice. So WHO group 3 pulmonary hypertension is a lot harder, and I show this picture of a wearable pulse oximeter, and I'm not advocating this specific brand. I don't have stock in them. I don't even know who it is, but I found this online, and I like it for a scleroderma patient to have these that fit over the thumb. And there's only a few of these. They're a little more expensive, but as you all know, a lot of you turn blue or purple out in your other distal fingers, whereas you're not usually blue or purple here. And blue or purple means you can't trust the oximeter. So pulmonary arterial hypertensions don't work quite as well. They don't work particularly well for WHO group 3 patients, so that's important. Keeping your oxygen saturation levels normal above 90 to 93% is really critical. I mean, that is the best treatment for this. And ILD patients with more extensive disease, obstructive sleep apnea, living at altitude are particularly at risk. And controlling these factors is critical. Oxygen is the best medicine. So what do we do for lung disease evaluation? Well, our history and exam, as we talked about before, helps direct us. HRCT in virtually all patients at the onset of their disease. Pulmonary function tests, including forced vital capacity and DlcO for most patients at least annually. For patients who have more severe disease or disease seems progressive, as often as every 3 months. Echocardiogram is a screening tool for pulmonary hypertension, as well as for something called diastolic dysfunction that can make you short of breath and can make your echocardiogram look like it might be showing pulmonary hypertension. The 6-minute walk test that many of you who are able to walk reasonably briskly will have done, and a test called the NT-proBNP or the BNP, which can be elevated if your heart is under strain from pulmonary hypertension or other reasons. So how about spirometry? What does it measure? Well, it measures how fast you're going, the flow, FEV1, the forced expiratory volume in 1 second, which is more relevant for asthma and COPD, and how much, the volume, the forced vital capacity. So spirometry is a simple expression of a complex process. It measures resistance in the airways. It measures the lung parenchyma, the chest wall, the respiratory muscles. This is why in a patient with bad myositis, forced vital capacity can look pretty poor, but when we look at lung volumes by another method, they look normal. It can show anatomic abnormalities. So someone who's had a severe injury to their chest wall here and can't inflate their lung, and body mass index can affect it. So the percent predicted is what we really go on, and the predicted values are different if you're older, if between males and females, your height affects them, your race and ethnicity actually affects them, and we come up with standards based on a huge clinical data collection study called the NHANES 2 study. And so based on the predicted value, we know where you should be, and we can tell how low or normal you are. So this is what's called the flow volume loop, and it's just a graph that represents how fast the air comes out of the patient, and the airflow rates are proportional to the airway caliber. So this is a normal flow volume loop. And we talk about your inspiratory reserve, your tidal volume, and your expiratory reserve. So this is how much volume you breathe in and out, and this is your inspiratory capacity here. So we look at all that. If you have obstruction from asthma or COPD, your flow rates are decreased, and your ratio of FEV1 to FVC becomes low. If you have restriction, which is what is the case if you have significant interstitial lung disease, your forced vital capacity values are too small. And then they have to be confirmed with plethysmography, the body box. Everybody loves the body box. So with interstitial lung disease, there's restriction of the volumes, forced vital capacity, and vital capacity are reduced. So you can see that here, the forced vital capacity here and the vital capacity. So this is with a patient with interstitial lung disease. You can see that both of them are smaller. So your lung volumes on body plethysmography are not affected by things like whether or not your muscles in your rib cage are working. You do your breathing maneuvers in a closed body box, and it gets at what we can't measure with spirometry, which is the residual volume. And it helps us to accurately determine the lung gas exchange with the diffusing capacity, which is a really important concept in systemic sclerosis in particular, because it's a key screening test both for active interstitial lung disease and for pulmonary hypertension. So the DlcO is the diffusing capacity for carbon monoxide. Carbon monoxide is, of course, present in all smoke. So cigarette smoke, campfire smoke, smoke from the exhaust of your car, and it's poisonous because it binds almost irreversibly to red blood cells and doesn't let oxygen bind. But used in tiny amounts, it also then lets us measure how well gas diffuses across the key membranes in the lungs. So this is the alveolus, the area where the oxygen comes in and the carbon dioxide comes out. And here's your your capillaries, the tiniest little blood vessels that let the blue red blood cells that are don't have much oxygen left in them and are getting rid of the carbon dioxide. They're coming from your brain and your toes and everywhere in between, and they are now picking up oxygen and taking it back to the rest of the body for your normal metabolism. So it measures the transfer of gas from the alveoli to the red blood cells. It's affected by red blood cell count. So if you're anemic, it looks lower. It's actually affected by all kinds of things, the time of day, if you're a smoker, if you just exercised, that skews it tremendously, if you're at high altitude. So as you can tell, when it's affected by all these things, it's a more variable measurement. And we don't get all worked up about a slight difference in your DlcO. It's usually decreased, however, commensurate with volumes in interstitial lung disease, and more than with volumes in pulmonary hypertension, and that's an important clue. It's unreliable in advanced ILD, where you have low lung volumes, and it also requires an ability to purse your lips to seal the mouthpiece. So for some patients with advanced scleroderma, this is a deal killer to do the DlcO, and you have to be able to hold your breath for 10 seconds. The 6-minute walk test measures the distance, shortness of breath, and oxygen saturation. These are the key 3 parameters that we are looking at. And it is useful for both interstitial lung disease and pulmonary hypertension assessment, but it doesn't distinguish the reasons for decreased distance, oxygen desaturation, or dyspnea exertion. Pulmonary hypertension treatments are largely approved by the FDA based on differences in distance, and that makes them less reliable in scleroderma, where sometimes patients have things like knee contractures that really affect their ability to walk. In systemic sclerosis, oximetry is probably the most reliable metric, but it requires a forehead probe so we don't get into those problems with your fingers turning blue while we're trying to measure it. Ear probe is pretty good. Sorry, I blew through that in a way I shouldn't have. The echocardiogram allows us to measure how well the atria and ventricles squeeze, how well they relax, if the valves leak, and if a leak across the tricuspid valve specifically is severe enough to suggest pulmonary hypertension. So if they don't relax well, that's called diastolic dysfunction, and that can make it look like you have low-grade pulmonary hypertension. But if there's a bad leak across the tricuspid valve, that's pretty suggestive of pulmonary hypertension, and we will send you to the cardiologist for right heart catheterization. And this is a bad leak here. The blood moving towards us, it looks red. The blood moving away from us looks blue. That's a bad leak. So if we put the data together, because none of these screening tests are super sensitive and super specific. So, and we already alluded to, we don't want to do right heart caths on everybody every year. So what's the value of putting the test together? Well, here's a nice study that was done in 2013 that shows that if you just look at the right ventricular systolic pressure estimate by echocardiogram, and you say, well, if it's less than 45 millimeters of mercury, they're not going to have pulmonary hypertension. Well, that missed up to 22% of pulmonary hypertension patients who had a right heart catheterization. That's unacceptable. We can't do that. Approximately 70% of those people were correctly identified if we said, what's the ratio of the percent forced vital capacity to the percent DlcO? And if it's higher than 1.6, that is to say, this is significantly better than this, 70% of those people, about 16 of them, we picked up as having pulmonary hypertension. So then they went and they looked, where are the numbers the best? Well, if your PA systolic pressure estimate on echocardiogram is greater than 35, and your percent forced vital capacity to DlcO is greater than 1.6, this has what's called a positive predictive value of 0.433. This is related to your sensitivity, but a negative predictive value of 0.978. And this is really good because now we say, if you're better than this, the likelihood that you're going to have pulmonary hypertension on a right heart cath is almost nil. But if you're worse than this, it's almost 50%. Well, you don't want to miss it. So then we send you, this is the kind of thing we say, okay, you definitely need a right heart cath. But we put it all together. So clinical decision rules are how we kind of proceed when we don't have great screening tests, but we can use several of them together. And that's what was done back in that slide. A decision rule is derived from original research, is defined as that it incorporates 3 or more variables from the history, physical examination, or simple test. It allows risk stratification for evaluation and management of presentations with risk of poor outcome. It limits testing that would otherwise risk adverse effects like the right heart catheterization. And it standardizes an approach to difficult to diagnose conditions, especially for those with less experience. It's one thing if you come to a doctor who's seen 800 scleroderma cases and they say this smells like pulmonary hypertension, but if you have somebody who's never learned to smell pulmonary hypertension, how do they do it? And it allows us to perform additional testing as needed to make a better prediction. So the NT-proBNP and BNP are measures of stress on the heart wall. I'm going to speed through this because I want you to have a little bit of time for questions, and I don't want to delay our next speaker. Significantly elevated levels of each have been proposed together with other screening tests to help decide when to perform the right heart cath, but it's also used to diagnose heart failure, exacerbation of heart failure, and there's disagreement about which test is better. And not all doctors even run these. I do try to do them. I think they're somewhat helpful. So, what do we worry about? Well, I worry about SSPD, sneaky subclinical progressive disease, where you're not noticing it and we're not noticing it. So the questions are you inactive with little ability to monitor your exercise tolerance? For one reason or another, you're not doing any significant exercise. Have you never had a high resolution CT scan? Is your doctor only ordering spirometry but not DlcO? DlcO is very important, as we've alluded to. Are you missing appointments or tests because of costs or COVID-19? I know this has been a big issue for a lot of people, and it may be okay. If you're quite active and you can monitor your exercise tolerance and you think you're fine, you probably are, but that's a risk. Are your PFTs slowly dropping but you're not having the other tests? Is your 6-minute walk test not done because you really can't walk well enough to do it? Are you blaming being out of shape for worsening exercise tolerance? Okay, so my patient I talked to yesterday wasn't blaming it. We did the screening test. The screening tests were reliable, and now we're probably blaming it, but only after we do the tests. So what should you do? Well, in general, you should be aware of disease manifestations that we can screen for and that will change therapy and outcome. So renal involvement. It changes outcome if we find renal crisis early, then we get you on the right medicines and we don't let you go into renal failure, which is a big deal. Heart and lung involvement. We want to know about shortness of breath, but also persistent dry cough, palpitations, chest pain, upper GI manifestations such as worsening reflux, difficulty swallowing, or pain with swallowing. Well, what else should you do? Exercise as you're able after clearing with your doctor. Exercise is almost always good unless it gives you chest pain. Inform your doctor if your exercise tolerance drops. If you get a new persistent dry cough for more than 6 weeks. If you have new or worsening leg swelling. That can mean pulmonary hypertension. It could mean a blood clot. Repeat screening tests as recommended. Ask your doctor about a home oximetry device if you know it doesn't take much to make you short of breath. Inform your doctor if you can't afford or can't tolerate your medicines. We actually absolutely want to know about this. There's ways we can sometimes help. And consider participation in clinical trials. I just remind you that you may or may not help yourself, but we may all get some newer, better therapies. So with that, I will take questions. Here's Ginger, our dog. She's lying right next to me right now, which doesn't normally happen at these talks, but this year is not a normal year. When she has a question, she raises her ear, so there is that. And I thank you for your participation and attention.
All right, thank you very much, Dr. Molitor. Now we'll do a few minutes of question and answer, and we do have a few questions. First question that was written in was not necessarily specific to your presentation, but with your experience. Thoughts on travel for someone who has scleroderma and is being treated with chemotherapy?
So it depends a little bit on what you mean by chemotherapy, and it depends a lot on what you mean by travel. So certainly if you have bad scleroderma lung disease to where you're short of breath with very little activity or at rest, flying is automatically a problem just because of the altitude and the lowered oxygen tension at altitude. And we need, it's really worth checking with your doctor who's treating you whether you need oxygen to fly. I'm sensing that the question may have something to do with COVID. Certainly right now, I'd be real careful about travel in general. But I think if you use good precautions, if you use the face mask, if you avoid being in crowded rooms, the risk is probably tolerable. Now, when you say chemotherapy, there is such a thing as chemotherapy that has lowered your white blood cell counts to dangerous levels. And you and your doctor need to have the discussion that's individual to you about whether in your case it's a okay idea to travel or really not an okay idea to travel. So I would say it depends, which I know is not probably a real satisfying answer, but I would need to know all those details before I would give a specific recommendation to a specific patient.
Sure. Okay, thank you. And then people, if you do have a question, if you could actually type it into your chat box, that would be awesome. All right, the next question. My 14-year-old daughter has been diagnosed with stiff skin syndrome and scleroderma. We have been to the U of M and Mayo. The doctors both said something different. Several tests and biopsies have been done. This has been going on for years. We just want answers. Is there a way to become your patient or get in contact with you? I think you gave your phone number before, but if you could reiterate that information, that would be great.
Sure. Our number is 612-676-5876, and be happy to review things. Generally speaking, we don't see people under age 16 in the adult scleroderma clinic. We do have scleroderma specialists in the pediatric clinic. I don't know if that's where you've been seen at the university. We can work all that out. And I do one-time consults sometimes on 14-year-olds, and then we could proceed from there.
Okay, thank you. The next one, they say, great presentation so far. Question for Dr. Molitor, is there a good diagnostic screening test for fibromyalgia? And also, is there a connection between scleroderma and fibromyalgia?
So the first question, no, there is not a good screening test for fibromyalgia. It is what we call a purely clinical diagnosis. It is the combination of symptoms and to a lesser extent physical exam findings. It is mostly a symptom-driven diagnosis. It is important that I go through this a lot when I'm training trainees, young doctors. Fibromyalgia is often thought of as a rule-out diagnosis. We rule out everything else and then we diagnose fibromyalgia. I don't think that's correct. Fibromyalgia can coexist with a number of conditions, including scleroderma. In general, it seems a little more likely to occur in patients with autoimmunity, but it's very common in the general population in which there's no evidence of autoimmunity. We don't really know what to blame fibromyalgia on, what causes it. There's been a lot of effort to understand that, and I'd say most of it's been only modestly successful at best.
Thank you. And then looks like we have just two more. They're commingled. Are scleroderma patients who take methotrexate considered high risk with COVID-19? And then that same person said, in addition to having high blood pressure.
So the best answer is we don't know. Of all of our medicines, the ones that I'm most concerned about probably increasing the risk of catching COVID are Imuran, which we don't usually use in scleroderma, also called azathioprine, and Cellcept, which we often do use in scleroderma. Those are the ones that I think are probably highest risk, just because of the way they work. Methotrexate is probably somewhat lower risk. What we've been advising patients is if you are sure you've had a contact, particularly a contact in the house, A, let us know, but B, if you're on Cellcept, and probably also if you're on methotrexate, you should probably stop those drugs temporarily until we can be sure that the period of time at which you're at high risk of catching it is over. It's not clear whether if you catch it, you're at higher risk of getting really sick with it. But in general, if you have bad lung disease, bad heart disease, those are the patients with the highest risk. It turns out probably that the vascular disease risks are among the worst risks for the disease. So that's high blood pressure, that's diabetes, That's known coronary artery disease or other atherosclerotic disease. Those are probably, those risks may even trump the risk of immunosuppression.
All right, it doesn't look like we have any other questions for you, Dr. Molitor. So again, we really appreciate your time. And it was a great presentation, so thank you very much.
Thank you.
Okay, now the second presentation will be by Dr. JoAnna Harper. And I'm happy to introduce our second speaker today, who is Dr. JoAnna Harper. Dr. Harper is CEO of Pain Partners and a clinical pharmacist provider specializing in pain management with personal emphasis in scleroderma and integrative medicine. She brings a unique first-hand approach to the effects of medications in scleroderma patients with her early childhood diagnosis of scleroderma and lupus. She's been working with the Scleroderma Foundation since 1994 in various positions. Dr. Harper is passionate about providing education, information, advice, and support for patients to become empowered to be active members of their healthcare teams. Today, Dr. Harper will be presenting Cannabis for Scleroderma, the Minnesota edition. So thank you for joining us, Dr. Harper, and it's all yours now.
Excellent. Can you guys see just one slide? Just the main slide?
Yes, you're good.
Okay, excellent. I'm working on a computer with multiple screens, so I'm making sure everybody's seeing the same thing that I think you're seeing. Okay, thank you everybody for having me today. And following Dr. Molitor is a really hard task, but I'll see what I can do. So I'm going to be talking about cannabis today, and so I've done this talk multiple times for the foundation in different aspects. So this, I did a complete revamp of the slides to make it very specific to Minnesota. So if you want further details on other aspects that are not necessarily Minnesota specific, i.e. growing your own, which is technically here, or anything else that is technically illegal in the state of Minnesota, please review one of my other talks that were recorded for the foundation. So today we're going to compare the difference between CBD and THC. We're going to look at CB1 versus CB2 activity and what that means to us as scleroderma patients. We're going to look at FDA approved products, which have been out for years. We're going to look at how to actually get a medical cannabis card in Minnesota and every grueling step associated with that. We're going to talk about side effects, concerns, and drug interactions in particular associated with your medications. So during those slides, only look at your medications. If it's a medication that doesn't sound familiar, move on, because there is a lot of information. I want to talk about the risks associated with THC products, whether it comes from the medical dispensary or whether it comes from a grown product. THC has its own inherent risks that I want to make sure everybody is very well informed before starting a product like that. And then ultimately, first and foremost, I firmly believe that a lifestyle of healthiness and well-rounded wellness lifestyle approach really is the most effective to treat pain, anxiety, and inflammation. So a lot of these medications, such as medical cannabis, can be helpful, but there never will be a miracle drug or a miracle product that will solve all of our problems. So as we talked about me, this is my lovely little miracle child. So the reason I have this slide here is to give everybody a little bit of hope that after 25 years of diagnosis, I was still able to get pregnant, have a miracle child, and still function as a pharmacist currently. So I have nothing to disclose. All of the other disclosures here basically discuss everything that the foundation talks about, as in this is for educational purposes only. The scleroderma affects everybody a little differently, so your medications need to be specialized for you. And all medical decisions, whether they're illegal or legal, prescription or not, should be discussed with all your healthcare providers so that everybody is in the loop and you get the best care possible. So, the question always is, ultimately, hemp versus marijuana, and what does that mean? And so we have to go into plant taxonomy for that. And so cannabis is the genus name for the species of plant that have both of those. And then hemp and marijuana are both two different species, and there's over 120 species of cannabis. So hemp usually is an industrial product. It's used in rope and other types of things. And it's a CBD topical product or an over-the-counter product as well. So that usually, all definitions aside, that usually means hemp is less than 0.3% THC of a product as far as that particular species of cannabis. Marijuana has, and we'll go through we'll break this out a little bit further here in a second, but medical marijuana or marijuana in general is a different strain, and that is the indica species. And so that one usually has much higher percentage of THC involved. So with the medical bill or with the Farm Bill for hemp, it made CBD over the counter legal if it has less than 0.3% THC. But the problem is the regulatory aspects are not up to par as of yet. And so many of these companies have not been tested. And so we're not exactly sure what's in the products. So we'll talk about that a little more in detail. So the history of cannabis, it's been around for thousands of years, hundreds of thousands of years even, depending on who you want to ask and what group they're part of. But a Chinese emperor used it for rheumatism back in 2737 BC. So it's been around for a long time. Here in the US, THC was banned in 1925, more so because of the effects of the molecule. And we were able to determine the structure of CBD in 1963 and the THC isolate in 1964. So that's where we started seeing the CBD and THC differentiation. And then in the 1967, there was the big euphoric effect of THC, and that's when the Controlled Substances Therapeutic Research Act came out in 78 to talk about they would allow research and they could recognize the medicinal value. But that being said, the strains that we are using today, because it is a plant and it can be modified for hardiness, that through genomics and other things, the strains that we were using for research were not as high or not as potent as the ones that we are using today for cannabis and medical cannabis. So there was a lot of question there. We are just now in 2016, we're allowed to use the stronger, more current strains for research, but ultimately federal law still prohibits cannabis as a controlled one or a scheduled 1 controlled substance. So that being said, federally, it is still classified as illegal. So when you talk about the endocannabinoid system and where where medical cannabis and CBD work, we started talking about this more in the 1990s. So it's still a relatively new system that we're learning more about. It moderates dopamine. And if you look at all the individual molecules, there's over 568 molecules. So that is a lot of variability where these compounds can work in the body. And then if you break that down a little bit further, there's 120 cannabinoids. So we have a lot of different options here for the actual compound where the body is working. So my whole point in showing the next 3 slides is just talking about how much research we have done in the last couple of years, in the last 10 years or so, and then looking at what more research needs to be done before we have a good, clear answer. But ultimately, these molecules help maintain the endothelium cell level as well as homeostasis and a lot of different metabolic processes. So when we look at these molecules, we look at different receptor types. And so there's CB1 receptor types and there's CB2 receptor types. CB1 is more in the central nervous system, in bones, joints, and ligaments, as well as the lining of blood vessels. And so CB1 allows for, it decreases excitatory neuron transmission, smooth muscle vasodilation, so that could be beneficial to us. Decreasing inflammation, that could be beneficial to us. But it also has the psychotropic effects, so that's that euphoric effect that we'll talk about again here in a little bit, but the high feeling. But it also is a pro-fibrotic. That is very concerning to all of us in the scleroderma community, as far as we obviously don't want to increase the amount of fibrosis activity that's going on. So most of the research for scleroderma, when it comes to the endocannabinoid system and different compounds, is the CB2 receptors. And those are the receptors that modulate the immune system, that induces cell apoptosis, which is cell death, decreases cell proliferation, decreases inflammation, and stimulates the regulatory T cells. So all of that can be beneficial to us as scleroderma patients. So it works on various immune cells, and it works on both the central and the peripheral nervous system, including microglia. And there's a question regarding microglia and memory when it comes to pain management. So those microglia can remember pain and still emit inflammatory cytokines, regardless of the environment it's in, even if the reason for the pain is decreased. And then also the locations are fibroblasts, muscle cells, and endothelial cells. So that's really what we're looking for the treatment of scleroderma and, say, MS and rheumatoid arthritis. So those are all very important to us. So the goal really is to have a product that works primarily on CB2 receptors and potentially modulating CB1 and using the benefits that we want without the bad effects. But the problem is THC binds to both. And as we'll see in a minute, the research behind that, there's still so many other options as far as other receptors and other research that needs to happen to better understand this. And the other thing that's really important also within your endocannabinoid system, polymorphisms, or the changes in each individual body and how the body can sense these molecules or break down these molecules, how the receptors bind. There's so much variability both in the individual person as well as the individual plant. So there's so much more to learn. So like we talked about, there's 568 unique molecules with 120 being cannabinoids. So all of that being said, if you look at the diagram here, these are obviously the conditions that have been reviewed for THC or CBD products. And then here's the different products and all of the different CBD versus CBC versus CBN, CBG. So this just shows that there is so much more in research that's being done right now that we don't have the answers to. So for example, with gastrointestinal issues, you have the THC and the CBD here, but if you look at multiple sclerosis here, you have CBD and CBN. But if you look at inflammation and arthritis, you have also an addition of THCA. So there's still so much more research, so much more hope associated with that. And then the other thing I wanted to point out, and we'll talk about this a little bit later as well, are terpenes. Terpenes are natural, and flavonoids are both natural products, and that cannabinoids being, or cannabis being a plant, the terpenes and flavonoids are in the cannabis plant as well. And what's important about that is we can get that from other things such as essential oils and food as well. So it being a plant, it makes it actually more complicated rather than less complicated. And so the other thing to keep in mind when somebody says a full spectrum product, they're talking about the whole plant, which has all of these molecules as a possibility. So when you're looking at a full spectrum, you got to take all of this into consideration. So like I talked about, this is just the tip of the iceberg when it comes to CBD derivatives and receptor activation. So all of these receptors, CB1, CB2, which we talked about, but now we have all of these other ones, the GPR55, the TRPV1, as well as the PPAR gamma. I know some of the scleroderma drugs, the newer ones, are looking at PPAR gamma as well. But it's important to see that all of these different derivatives here on the left-hand side here are looking at what receptors, and we're doing further research to see exactly what receptors they're hitting and getting more details. So more research to come. So the differences between CBD and THC. So CBD is known for the inflammatory reduction, and so decreasing inflammation is really important. There's a lot of antioxidant properties. We do use the CBD products for seizure disorders as an antidepressant or an antipsychotic, and some have indicated that it can decrease irritable bowel symptoms or the GI symptoms that we feel with scleroderma. There is some research stating that it may reduce tumor effects, which we're still getting more details on that. But there are over 30 different metabolites for CBD alone. And so mainly CBD should be more CB2 activity. Now THC is more for nerve pain and muscle pain and for sleep. So that's the one that we're using as the cat on, the cartoon. At any rate, Puss in Boots talks about, he uses it for his glaucoma. So that is more of the that's more of the psychosis or the euphoric effects is the THC. But it is also helpful with anti-nausea. And so so THC in general has CB1 and CB2 activity, but it has over 100 different metabolites. So we're looking at a lot of different, different ways that the body needs to break it down and process it. So that's more variability associated with this particular drug. So if we look at CBD versus THC, CBD seems more directly associated with our symptoms directly, but also less metabolism issues to be concerned about. We'll talk more about that with drug interactions later in the talk. So the available products, now these have been out forever. These are prescription items that your provider can give you. Dronabinol has been around for a long time. It was used mainly for nausea and vomiting and weight loss associated with HIV or cancer. Primarily, it does bind to CB1 and CB2. So both of those receptors, and again, we don't know if CB1 activity will benefit us or not, or if it will actually hurt us yet. But dronabinol is an option that can be prescribed with your provider if you meet the criteria. And then nadolone or Sesamet is another one that came out more recently. And then Epidiolex is the one that was pushed for seizure disorders in children. And so that one was that's the first one that was FDA approved that is mainly CB2 activity. So again, CBD versus less of the CB1 or THC activity. So question is, how do you obtain a cannabis card here in Minnesota? I worked in the pain clinic for multiple years, and I worked behind the scenes, and I've seen the challenging aspects. So I'll give you all of my insider information with a step-by-step guide on how to do it. First off, I recommend deciding on, first off, is this product the best product for you? So number one, do you want a product that has THC involved? That euphoric effect, the potential question as far as whether it's going to hurt scleroderma symptoms or not with the pro-fibrotic, or if that's still an option that you want to try. If you do not want THC at all, you don't have to go through this process. There are CBD products available that do not include any THC or are below the 0.3% to make them legal over-the-counter products. Now, if you've decided that you do want a THC product, first off, I recommend deciding on the patient cannabis center that you want to go to. So here's all of the steps, and we'll go through these step by step. You can refer back to this slide if you need to with the brief overview, but briefly, you see the patient cannabis center, you decide on that. You see your provider for diagnosis and condition. You make an appointment with the cannabis provider. You respond to the email from the Office of Medical Cannabis, respond to the second email, and then you visit the Medical Cannabis Center, finally, and then you log into the registry for self-evaluation, and then it does require annual recertification. So if you look at each one of these steps, there is a fee associated with most steps, and the fee can be can add up to be quite a bit to have that THC component. So the first step, do you qualify? So that's a big question. And here in the state of Minnesota, the qualifying conditions are cancer, chronic pain, PTSD, inflammatory bowel disease, severe or persistent muscle spasms, obstructive sleep apnea, autism, terminal illness, severe or chronic pain associated with terminal illness, or the nausea, vomiting, and cachexia with terminal illness. Now, terminal illness means less than a year to live in their definition. So really, terminal illness is not going to apply to a large group of us. Hopefully, I love y'all. And then the biggest things I want you to note here, it does not include anxiety. It does not include depression. It does not include insomnia. It does not include MS. Well, severe and persistent muscle spasms can be classified under MS, but that's not necessarily a symptom of scleroderma. So it's very symptomatic, or it's based on symptoms. And so your doctor would have to have one of these qualifying conditions for you to be eligible to obtain medical cannabis in the state. So most of the time it's going under chronic pain currently, or PTSD. Now there is a lot of extra scrutiny with children and anybody with a personal or family history of psychosis. So both of those the benefits would have to far outweigh the risks for that one. And then the caution is associated with immunocompromised, which again, as Dr. Molitor had discussed, there's levels of immune compromise that's associated with scleroderma and the medications you're on, so on and so forth. So that would have to be discussed with your provider initially, and they would have to have the diagnosis listed with that. Now, where cannabis is contraindicated is if you have active addiction problems, any type of addiction, whether that's Amazon Prime addiction, whether that's gambling addiction, whatever the case may be, that is something that needs to be addressed. And I say Amazon Prime as a joke, as I'm sure y'all are in the same boat. And then active psychosis or pregnant and nursing mothers. They usually will not accept that as a condition where they will accept medical cannabis use. And then the other things for Minnesota specific, you must have a Minnesota ID or an out-of-state ID, passport, or other photo ID, plus a bank statement or utility bill stating that you are a Minnesota resident. So those are absolutely required. And then after you see that you meet those, if you meet those qualifications, you go to your provider and you need medical records or documentation of diagnosis from your medical record to proceed. So I usually recommend picking the cannabis provider that you want to go to first. So the provider is Life Medical, can certify you for medical cannabis, unless of course your doctor is certified. And a little drop to Dr. Molitor, any doctor can become certified. But I understand that there's a lot of complications with that when it comes to the clinic that physicians are in, as well as the busyness of their practice. So oftentimes you have to see another provider for a cannabis certification. And so your cannabis provider Life Medical can certify you. For the initial certification, it's $250 on booking, but it will be refunded. And I did call to verify all of this, so it's the most current information. And they do give a discount to veterans of about 25%, or about, I'm sorry, 10% at $225. And then you need to recertify every year at $200 or $180. And that does require a Zoom visit. They do have multiple locations after when COVID activity decreases. And their phone number is there that you can call and make an appointment for them. Advanced Spine and Pain Clinic also does it, and they are actually a little cheaper. I was going by basically size of locations on how I numbered these. So Advanced Spine and Pain Clinic, they have less locations around town, but they are cheaper, and they are doing virtual visits as well. They are $200 for initial screening and then $175 for recertification. But the good thing with them is with recertifications, they do give a significant discounted rate for any type of medical assistance, VA, Medicaid, or SSDI at $50. And then the Park Nicollet Pain Clinic, they do not advertise this, so this is my insider information, but I did talk to the provider there who does most of these, and so she is okay saying this. If you have a Park Nicollet provider, whether that's your primary care provider, whether that is rheumatology, whether that is ortho, any Park Nicollet provider that you see can send a referral to the Park Nicollet Pain Management Clinic. It is a specialty clinic copay, so whatever your copay is, but there is no additional cost for medical cannabis certification. Unfortunately, though, they will call you for an appointment and it can take up to 45 days. So that process takes a little longer, but it usually is cheaper for this certification. So the next step is seeing your normal provider. Are they a medical cannabis certified provider? If they are, problem solved, moving on. And then they can do the rest of the process with you. If they are not, you have to obtain medical records. I would get a copy for you with a qualified diagnosis and your medication list, and then have them fax your medical records to the cannabis provider of your choice, which is why I have you choose your cannabis provider first, so that that's a one-stop shop. While you're in the office, you can decrease the paperwork both for you and for them to have them fax over your medical records to that cannabis provider. Again, if it's Park Nicollet, they have to send a referral to the St. Louis Park Pain Management Clinic. And by no means does that mean health partners. This is just Park Nicollet providers because they could not handle the whole caseload of the whole system. And then the next step is you make an appointment with that medical cannabis provider. So again, here are the phone numbers for the cannabis providers. You need to provide a good email to this cannabis provider when you're there. So that email is what the state will use to contact you back, and you need that email to move on. So basic computer literacy is absolutely vital for this process. So get your nearest millennial or grandchildren, children, if you don't know the process well, but it's just email and it's clicking on links, but making sure that you get those emails are vital. So step 4 and 5 are all your responsibility. An email will come to you from the Office of the Medical Cannabis, which is part of the Minnesota Department of Health. And you need to respond with you need to register, and you need to include that proof of residency we talked about. So that's your ID, Minnesota ID, or another out-of-state ID with, or your passport with a utility bill or a residential bill stating that you are a resident in the state. And you have to pay the annual fee. And the annual fee, I think I mentioned it somewhere else, but it depends on whether you're, I think it's $200 as an annual fee, but I think we'll see it in the next email. And then you will respond to the second email as well. So the annual fee is about $200. or I think they give a discount with Medicaid as well. And then you will receive a second email that has a self-evaluation. If you complete that self-evaluation, that is your approval letter for medical cannabis in the state. And so that allows you to make that appointment with the medical cannabis, or allows you to get your medical cannabis card and then move to the medical cannabis dispensaries that we have here. So that's not confusing enough. The next step and the last step is actually getting your product. So there's cannabis patient centers, and these are the ones that are located around the state. And there's only 2 facilities. You have Minnesota Medical Solutions, or you have Leafline Labs. I only gave you the phone numbers for locally, for within the Twin Cities area, but that website there has all of the other sites that are listed here. During COVID, they are doing telemed visits with a pharmacist, and they do allow caregivers to allow them access to pick it up curbside for you so that you don't have to leave the house. Now, during the pharmacist visit, they will evaluate your medications and your needs and your symptoms, and they will determine what product is appropriate for you. From my experience in the pain management clinic, they often start with a 50-50 CBD THC product, which is not appropriate for all. I can't stress that enough. So if you're nervous about the things that I just talked about THC, the euphoric effects, the sedation, all of that, or the pro-fibrotic effects, I would talk to them about a higher CBD product to start with. And then we'll talk about dosing next in a few slides as well. But ultimately, make sure you express your needs as well, because they're going to try and steer you towards a 50-50 product, more for cost, but also because that's their starter packs. And it's kind of a cookie cutter approach. And I am anti-cookie cutter approach. I'm very individual medicine. And so your conversation with them will help you get individual care or individualized medicine for yourself. So the products here are the products that are available in Minnesota, and both sites have the exact same process or the exact same products. And so you have the CBD dominant ones on the right, and they're the blue, indigo, and violet. And those are the ones I really prefer you guys to be on, at least initially. If I have my choice, I would do violet, but interestingly enough, violet is the most expensive, and the price decreases as you go to your left with more THC. And so most of the products they're going to use are yellow and green to start with, and then with the black and red being primarily for anxiety and insomnia. So the products that are also available, so we talked about doing just CBD only products. So if you're telling me that you don't want to be involved in this THC at this point and you want to try just CBD products, I highly recommend trying a CBD product first, over the counter, for cost, because there's a lot of money with the certification. So you have the doctor visit, initial doctor visit, you have the certification from from the medical cannabis doctor, and then you have the certification for the state, and then you have the actual product. And the actual products run averagely anywhere from $100 to $300 a month, but usually they're about $200 on average per month per patient. So it is a costly endeavor to include THC. So if you're looking for a CBD product that's over the counter, I recommend trying those first. You can go to your local co-op or natural food stores. Always ask them for proof of purity or concentration. Make sure that that company verifies their product after each batch. So they're making sure that there's no impurities and that there's no concerns about any type of funguses or bacteria or anything else that can seep into the process. If you listen to my last talk, I go into that in excruciating detail because there are a lot of concerns about the purity of the product, and we have no control over that because it is an over-the-counter product. And then there's a question of whether they're providing medical advice at the local co-op or the natural food stores. So please use my information here to help with product selection. Broad spectrum, it is important to know that you can test positive for THC with a broad spectrum product, even if it says it's less than 0.3% THC. So I would go for the zero CBD or zero THC products, or go with the topical. So both of those I prefer. Topical products, I'm not as concerned with the amount of THC over the counter, because oftentimes, as long as it's a verified product. And then there are products that are provider only products, which I do have access to these. I've given you the Revive information, and I've given you ECN. The Enhanced Clinical Network is the products that I prefer. They are 100% CBD only. They do verify after every batch. They do have capsules, they have oil, as well as lotion. I believe the lotion works fabulously well, but that is just a personal opinion on my end. There are other CBD products that can work well for other people better than ECN. And then Revive MD also has full spectrum or THC products. So they do have a product that does have THC in it if preferred, and they also have flavored oils. And so their information for you to order is there. If you are interested in ECN, the Enhanced Clinical Nutrition, let me know. My information is at the back. There is some association with using these products with improvement in symptoms. So that is the reason I do provide that access as a provider for these products. So as far as dosing is concerned, whether it's OTC, over the counter, or medical cannabis, always start low, very low, and go slow. And my goal is for you to stay low. If you need to escalate doses, I classify that as a treatment failure. So it will take a lot of time for you to figure out the exact right combination, the right product for you, as well as the right dose. So this is a long process that you need to take your time and start low. I can't stress that enough, because the THC effects for those that get them, that euphoric kind of out of body feeling, can be scary to some. And the older you are and the more medical challenges that you have, the worse the symptoms can feel to you. So I always recommend a low THC product initially, as I've discussed already. So as far as products that are available, you have oral products and you have oils, which are usually the most potent. And then the next one, as they go down in potency, are tinctures, edibles, oral sprays, or lozenges. And those have an onset, so how quickly the drug starts working, 60 to 180 minutes. So it could take a while. Don't take another one until you have that one and you figure out what that one does. So wait 3 hours before you do anything else. This is not a quick process. And they can last up to 6 to 8 hours for an oral product. Topical, which are creams or suppositories, it's all variable based on skin thickness, which we all know is variable for scleroderma patients, but also, it depends on, the amount of fat tissue, so on and so forth. So again, just be patient with them. And then I never recommend inhaled or vaped, especially for scleroderma patients. Excuse me. Sorry about that. So smoking or vaping is a quicker onset. It lasts less time, but I don't recommend encouraging any type of smoking or encountering anything further within the lungs for scleroderma patients, as Dr. Molitor has kind of already expressed some of the lung concerns. So the side effects. So CBD side effects, nausea, which is interesting that it can be used to treat nausea. Changes in mood. There is some mood components associated with the CB2 receptor. Irritability, fatigue, and anxiety. Now, if you look on the other side, THC, the list is much higher. So you have nausea or hyperemesis. So I want you to know that it can be used to treat nausea, but it can also cause you to vomit in cyclically. So you keep vomiting over and over. If the dose is too high or you've taken too much, everybody talks about the munchies associated with THC, sedation, but also dry mouth. With scleroderma, the dry mouth can be very profound with THC products. And then confusion, memory loss, hallucinations, decreased IQ, lack of coordination, euphoria, vasodilation, so it can actually vasoconstrict to your fingers, decreased sexual abilities, acute pancreatitis, and also withdrawal symptoms. So a few of the other things I wanted to talk about very quickly are the THC risks. So there is still a risk of addiction associated with THC. There can be worsening heart disease if you already have heart disease. There is an increased risk of heart attack and a reduction in lung function. There can be neurotoxic effects in children, and there's a question of whether there can be neurotoxic effects after many years of adult use. The most common emergency is actually a panic attack with THC containing products. So again, low THC to start with, and then increased psychosis. So worsening of schizophrenia, possible development of schizophrenia, and some of that can be irreversible. We talked about the hyperemesis and the sterility issues as well. So the addiction aspects, cannabis. So this is just cannabis in general. So it doesn't break out THC versus CBD. So it is, we do need more research in this. But if you look, the physical harm is about a 1 when it comes to CBD and THC studied together. But it's right up there with like ecstasy or LSD. So that's a question that you need to ask yourself. And then the dependence is actually a little higher, and it's similar to that of buprenorphine or Suboxone and ketamine. It's not nearly as high as heroin and cocaine and tobacco, I get that. So I do see that there's less harm overall and less dependence, but it's still something that you need to weigh into your decision. And so then also, you know, is there some dependence? So this was a study back in, I believe, 1994 that showed 9% of patients became dependent on this medication. So the risk is probably a lot higher now based on the strains that we're using, but in children that risk increases significantly. So there is something called marijuana use disorder. Again, if you're using larger amounts over longer periods of time, if it has undesired effects and you still continue to use it, if you're unable to cut down or control your use, if you have cravings with it, if you're working really hard to get it, to use and to recover from any of the effects, that's another symptom of marijuana use disorder. If you're unable to fulfill your obligations at work, home, or school, or if it's affecting your social or interpersonal relationships and creating problems there. If you're giving up things that you normally enjoy, and tolerance and withdrawal are possible. So if you stop this medication, there can quickly or abruptly, there can be some withdrawal effects, and tolerance does develop over time. So again, these are all things we need to consider. So drug interactions, we have limited data based on the Epidiolex that came out. And so that's the information I'm going to provide you now. It can make the CNS depressant effect, so sedation being one of them, incredibly much higher if you use it with benzodiazepines like alprazolam or Xanax or Valium, diazepam, alcohol or opioids. So I don't recommend using those products together. It can have mania with SSRIs like Prozac or it's an antidepressant, Prozac, citalopram, Paxil, any of those. It can have increased tachycardia or delirium with tricyclic antidepressants such as hydroxyzine. And then increased risk of immunosuppression with corticosteroids. So these are all concerns that you need to bring up with your doctor. And then may decrease the effects of antipsychotics. And then it does have competitive metabolism with very, very common CYP enzymes or liver enzymes that are used to process so many other drugs. So the ones that I'm really concerned about for scleroderma patients, so these are the medications that can increase the effect of THC or CBD. And so amiodarone, grapefruit juice, cyclosporin, let's see here, cimetidine or Tagamet, fluoxetine or fluconazole. Those can all make it feel like the dose of THC or CBD is much higher than the dose you intended because of that drug interaction. So the next one, meds that increase the THC. So this is THC specific. So Plavix is one that's very specific to THC. Leflunomide, which sometimes is used, as well as valproic acid, so less, and as well as fluconazole again. These are the ones that, the medications that can increase CBD. So again, Tagamet, fluconazole, fluoxetine, and omeprazole. So that's very important. So starting lower, if you're on omeprazole, starting a lower dose of CBD would be recommended. So the CYP2C9, or these are the ones that decrease THC. So it makes it to where it feels like the THC is not effective. So you may need a higher dose, but I would not start at a higher dose. The Tracleer, which is often used, phenytoin, as well as St. John's worts. And then the next one, these are the ones that can decrease CBD. So Tegretol, the dilantin or phenytoin, as well as St. John's wort. And these are the ones that can decrease both THC and CBD. So that's bosentan or Tracleer as well. Modafinil or Provigil. So a lot of different options here with drug interactions. So I would take this to your provider to really assess whether this medication is right for you. So safety concerns, as we talked about, medical versus not medical. If you are getting it somewhere else and having it shipped in, I don't know about it. But I will say, know where it's coming from, everything from the soil to the air to the water to the purifier to how they break it down to how they make it in oil, all can get contaminated. So make sure there's extensive lab testing. I do prefer topical as it decreases the drug-drug interactions, but also oftentimes can get good effect with very limited systemic absorption. And then vaping, I never recommend vaping as I talked about, but there is antimony and tin in the vape pens. And so nothing's been tested as far as whether that antimony and tin leak or seep into your system as well with the burning of the pen. And also increases the risk of lung disease and infections, as well as the plasticizers that are used. So a lot of compounds that I don't recommend going into your lungs. So promising new medications. There are CB2 products specifically for scleroderma coming out. Emerald Health has one at the bottom here, which is the CB2 and the PPAR gamma. And it has promising anti-inflammatory and anti-fibrotic effects, as well as recovering damaged blood vessels and even reduced skin thickness in mice. So it's very, very promising there. Corbus had another one here that was also looking at CB2. Now they have found that this particular product right here was not effective for scleroderma. They are using it for lupus and other things. They're still testing it, but that doesn't mean that they're done testing that just particular product. They have other products as well that they're going to continue researching for scleroderma. So go Corbus on that one. And so here are the other promising ones that we're using right now. And again, looking at those different receptors that were in those cool charts before that seemed way overwhelming at the beginning of this. So important tips. I'm winding down, people. We're getting there. We're almost done, I swear. Try CBD first. THC is much more difficult to tolerate for many people, and I do recommend microdosing initially. So very, very low dosing, as low as you can possibly measure. And then THC can increase anxiety and nausea, even though it's touted to decrease that. Make sure you know that it can increase it as well. Communicate with all your providers, psychiatry, primary care, rheumatology, all of the above. Anybody you see, make sure they know, even if there is that stigma associated with it. As you see, there are a lot of drug-drug interactions that would go unnoticed, and they would be blamed on another drug if you're not communicating with them. If you have current drug abuse, I don't recommend cannabis at all. This review state laws. So I want you to know, here in the state of Minnesota, oil and edibles are felony charges in the state of Minnesota. And so if there's a real concern there, I do have a friend of mine who had that happen. So just let you know, it is a felony. And those can be readily available through the mail. Driving under the influence, that is a real concern, whether you're impaired or not. If you test positive, you can be charged with driving under the influence, even if you're on a CBD only product, like we talked about. So that's why I recommend topical. Unable to travel between state lines, even if they are a medical cannabis state. Do not share, sell, or give away your medical cannabis. It is still a prescription, and it is only authorized for your use. The goal is to wean opioids and benzodiazepines slowly. The goal is not to keep you on everything. The goal is to find the most appropriate product and to increase your lifestyle healthiness overall, create some mindfulness and meditation techniques. And I promise, I've been there, I'm a patient too. They really do work. They just take a lot of time and effort. I don't recommend any vaping or smoking. Genetics really affect the metabolism. So some people have no problems. Some people have problems at very small doses. And then many drug-drug interactions, as we talked about. So with pain management, always look at the source of the pain. Always look at all available sources to treat the pain more effectively, rather than just reaching for a medication. Medication should not be the only answer for pain management. And address the root cause. So with functional medicine or looking at inflammatory processes in your life, whether that's diet or stress, make sure you look into that as well. And then there are all sorts of other options if you're doing it for pain, such as low-dose naltrexone, gabapentin, duloxetine, et cetera, et cetera. So other dietary options, increase the beta-caryophyllene is also in bitter greens, which is that terpene. Bitter greens, black pepper, oregano, and cinnamon, so you can increase your dietary intake and still get some effects from the same receptor. And then focus on wellness. There is no magic. I would love if there was magic. I've been looking for it for 25 years, but I will tell you that the magic that I have found is taking one small step in the right direction every single day. So I know that that was very lengthy. I do apologize. Here is the conclusion. I've kind of gone through all of this already, but most importantly, I want you to be an active member of your healthcare team. Doctors can help. They can help guide you, but ultimately they cannot come home with you. So that is your responsibility. Reach out, do some research, look at available options, and then speak to your healthcare providers, but also talk about the healthy lifestyle management with an integrative approach on wellness for yourself on a day-to-day basis. So thank you, everybody. These are important quotes to me. And then at the end, there is also a slide with my contact information that I will flash up during the questions. Any questions?
All right, thank you very much. So any attendees, if you have any questions for Dr. Harper, please go ahead and put those into the chat and we will pass those along quick. Right now, we don't have anything that I'm aware of.
Okay, here is my contact information. So what I'm telling everybody right now, I have taken the time for myself as a patient to actually practice what I talk about. And so I have been spending the time to do a lot of self-care and develop those develop the healthy self habits for myself. So if you do email me, it may take me some time to respond, as I am concentrating on me currently, but I can answer some basic questions, and I am looking at starting a service as well. I'm hoping to get that going in the near future, and I'm hoping to be able to get some type of billing reimbursement, or maybe some drug company funding. Hint, hint, those drug companies that I've talked about, hoping that maybe we can get some way to get some of the consults available to you from more of a functional medicine approach. Okay, somebody has to have a question. I love you all.
All right, Dr. Harper, at this point, we don't have any questions. So that tells me that you covered every base possible, I think. We don't have anything, but we can just kind of hang here for maybe we'll go like 2 more minutes, give everybody a chance to ask if they can think of anything they need that is in their curiosity wheel anyway.
And my email information is there
Yep.
for other questions as it comes up. So I'm available.
Perfect. All right, well, don't have anything yet for you, so I'll just do a quick little closing, and we'll keep an eye out to see if any questions pop up in that meantime. But in closing, we would like to thank Dr. Molitor and Dr. Harper for their time and their expertise with us. And we appreciate everybody that logged in or dialed in today to attend this. It was greatly appreciated. Be well, stay safe. And we still don't have any questions for you, Dr. Harper, so this will conclude the webinar for today. Thank you very much for joining.